Good evening. My name is Lauren Lele, and I am the Director of Community Benefits at Newton-Wellesley Hospital. Thank you for joining us for the second part of our two-part series titled Medical and Surgical Treatments for Heartburn and Reflux, hosted by the Heartburn and Reflux program at Newton-Wellesley Hospital. Before the program officially starts, I would like to mention a few logistics for the next hour and a half. We will be leaving plenty of time for questions and answers, and would ask that you use the Q&A feature at the bottom of the screen to type your questions in. However, if you're more comfortable using the chat, that is perfectly fine as well. I will monitor these questions and be asking them of our speakers at the end of the presentation portion of the program. And now let me tell you a bit about who we will be hearing from tonight. Dr. Charu Paransape is the Associate Chair of Education in the Department of Surgery at Mass General Brigham's Newton-Wellesley Hospital, as well as the Chief of General Surgery and Acute Care Surgery at Newton-Wellesley Hospital. He is the founding director of the Heartburn and Reflux program, which involves multidisciplinary care with gastroenterologists, surgeons, dietitians, and advanced care practice providers. In addition, Dr. Paransape performs minimally invasive and robotic foregut surgeries at Mass General Hospital and serves as a trauma, acute care, and critical care surgeon at Mass General Hospital. Dr. Benjamin Levitsky is the Assistant Clinical Professor of Medicine at Tufts University School of Medicine. He earned his medical degree from Temple University, completed a residency in internal medicine at Boston Medical Center, trained in gastroenterology at the Cleveland Clinic, and completed further training in advanced therapeutic gastroenterology at UMass Medical Center. His clinical interests include general gastroenterology, colorectal cancer screening, gastroesophageal reflux disease, inflammatory bowel disease, and advanced therapeutic endoscopy. And now, to begin our program, I will turn it over to Drs. Paransape and Levitsky.
Thank you so much, Lauren, for that kind introduction. Dr. Levitsky and I welcome all of you guys today, this evening, to spend some time with us to learn about the common reflux disease and what we sort of do for that. In the part one of the program, all of you have heard from our two excellent team members, Alex Malby and Sarah Andrews, about the dietary and other aspects of the GERD. Today, we're going to concentrate upon the medical aspects of medical management of the GERD and also the surgical management. So before we dive into the medical management of the GERD, I would love to share my slides and just discuss a few things about heartburn in general, and then I will hand off the presentation to Dr. Levitsky. So I'm going to share my screen here. And so why are we even talking about this, right? So we have a crisis, people, as we all know. About 20% of US population suffers from heartburn or GERD and takes some form of anti-acid medication. And that's why it is so popular that, if you are watching an extended game on the TV or seeing a program on the TV, you're almost guaranteed that you will see at least some anti-acid advertisement. And because of all these things that are there on your front of the screen, This was not so much of a entity, let's say in 1960s and 70s, but lately, as we know, GERD has become very common. And it's because of, number one, our lifestyle has changed, our food choices have changed, and obesity rates are, significantly higher. This graph tells you how our obesity rates have increased in our country from 1960s to the 2000s and beyond. And similarly, the rate of GERD has been parallel to this. Part of that is because of our diet. As you can see in this picture, all these new things that we add to our diet. Caffeine has become our national drink, as we know. United States ranks very highly in the caffeine consumption in the entire world, and that has led to this phenomenon that 1 in 5 person takes daily medications from the GERD. But the problem doesn't stop there. Parallel to this, we are seeing an alarming rise in the incidence of esophageal cancer that is because of a different type of cancer. A few decades ago, we had all the esophageal cancer, predominantly the squamous type, which was basically as a result of smoking, alcohol, and some other genetic changes in the patients. However, now we're seeing the predominant form of esophageal cancer is adenocarcinoma, which is directly due to reflux disease. And this is the trend, which is extremely concerning. But what have we done about this? Like I said, there is a tremendous increase in the sales and advertisements of all these medicines, which are excellent, by the way. But we, as medical community, we have just spent more and more dollars on this, but haven't done a sort of a combined effort to treat this. So if you look at what in general has happened, is we have siloed the care of reflux disease into different specialties. Me as a surgeon, Dr. Levitsky as a gastroenterologist, and the primary cares who treat this disease every day, we've all been in silos, and we don't really treat our patients together. And so, and forget about seeing a dietitian or an advanced, practice provider. Nobody even gets an access to see a dedicated dietitian, even though we all know diet has significant, it's a significant portion of why the GERD starts in the first place. And so the poor patient essentially are, stuck between this kind of dilemma where, one person says one thing, the other person says the other thing, but not everybody comes together and forms a combined team. So here at our Newton-Wellesley's Heartburn program, we've been fortunate to put this team together where you will see gastroenterologists such as Dr. Levitsky, Dr. Curtis, Dr. Calmet, surgeons like myself, Dr. Schumacher, a dedicated dietitian like Sarah, a dedicated PA such as Alex, who you've heard last week, and then Anna, who's our coordinator. All these people come together and treat the patients at one location with all the state-of-the-art tools in our toolbox. So we have the state-of-the-art diagnostics, state-of-the-art therapeutics, which will include endoluminal, that means incisionless, and also through the endoscope treatments, and all the minimal invasive treatments such as the laparoscopy, robotics. But in addition to this, the stress is on lifestyle modifications, diet modifications, all offered in one location with sort of a one-stop shop type of approach to make specific tailor-made plans for each of our patients. And that has made the big difference. And that's why it's been a pleasure putting this center together with this team. And multiple of our patients have loved the concept. Our primary cares have loved the concept. And so over to Dr. Levitsky to explain who do we treat, how do we treat, and how do we treat these patients medically. Over to Dr. Levitsky.
Hi, do you hear my audio? Terrific.
Yes, we're all
Okay.
set. Thanks.
Terrific. Thank you. Hi, everybody. Thanks for coming tonight. Thank you, Dr. Paranjape, for the introduction. I'm Dr. Levitsky. I am a gastroenterologist. So we treat many people with upper GI symptoms at the Newton-Wellesley Hospital's Heartburn and Reflux Center. And we try our best to personalize management for an individual patient who may have reflux symptoms, a complication of gastroesophageal reflux, or other potentially related esophageal disorders. There are many patients that come to us because over-the-counter medications or prescription drugs are not fully alleviating their complaint. And for other patients, actually, their concerns are medication and lifestyle changes simply are not working because there's an underlying medical condition that's yet to be diagnosed. Some people with reflux are also simply searching for some treatment option that's more durable and an alternative to a lifestyle where they're using chronic medications to manage their symptoms. So our goal is quality of life. Many of the diseases that we treat are manageable, and our goal is not simply to giving a treatment, but to improve the daily lives of patients with a multiple disciplinary approach that will include educating patients about the disease that they have and the symptoms that they have, what role lifestyle plays in upper GI symptoms, as well as review both medical options for management and surgical options for management when lifestyle and dietary modification measures fail. There's essentially a team-based approach that we tailor to a specific patient around their goals and expectations for care. Now, coming to a heartburn center, the first question that we try to get at is it actually reflux? So coming in and saying, I feel chest discomfort, I feel burning. Well, is it truly acid that's driving that symptom? And there are ways that we can actually answer that question. On the left, you can see this green rectangle in the left aspect of the picture here. This is a pH monitor that can be placed in the end of the esophagus and wirelessly transmit data to a monitor as it's monitoring for acid over 3 days throughout the course of this study. And this gives us good information as to what is happening in the end of the esophagus at any given moment in time. And if a patient has symptoms, do those symptoms that they feel correspond to a moment of acid reflux? On the right side of this picture, you'll see a second diagram where there's a man with a device in his nostril. And this is actually a different pH device that monitors acid reflux. And it monitors acid reflux all the way from the lower esophagus to the neck. So if a patient's having a chronic cough or a feeling of a globe in the neck or a foreign body sensation, well, what's going on up here? Is that actually reflux up in the neck, or what we call laryngopharyngeal reflux? We can monitor for these things. When we're asking ourselves, is that burning reflux? All that burns is not reflux. Here's a slide that has a radiograph, and you can see this column over here. This column over here is an esophagus that can't clear itself. The patient drank barium, swallowed it, and it stays pooled in the esophagus. Why could that be? Well, the lower esophageal muscle sphincter doesn't relax. So they're feeling burning in the chest from a lack of an ability of an esophagus to clear, which is not reflux. This is a motility disorder of the esophagus called achalasia. There are other types of motility disorders where the esophagus doesn't contract in a normal way that can mimic acid reflux. Some patients actually have esophageal hypersensitivity. And what that is a very sensitive set of nerve endings in the esophagus that feel stimuli extremely sensitively. So even the tiniest little bit of reflux that would be within the normal limits can lead to a severe feeling of burning if the esophagus is quite sensitive. There are other diseases that we want to make sure that a patient with heartburn doesn't have. There's a process called eosinophilic esophagitis, which is actually an allergic reaction of the esophagus to food that's being ingested. And rather than treat for acid reflux, we need to figure out what that food is and eliminate it from the diet. So hence all that burns is not GERD. Now, the vast majority of our patients actually do have GERD. And so there are multiple medical management options for GERD. And starting from things that cause zero side effects, we can start with lifestyle modification. You know, weight loss is an effective strategy out of the starting gate. Decreasing the pressure in the abdomen means that ingested food and liquid in the stomach is less likely to regurgitate back up to the chest. Many patients will have triggers for heartburn, and they can tell you what they are. Commonly, they're highly acidic foods, chocolate, alcohol, peppermint, caffeine, highly fatty foods, citrus, tomatoes, tomato sauce, Thanksgiving, turkey, and so there are many different foods that can trigger heartburn. And if a patient feels them, clearly avoiding them. Timing of meals is also important. If you eat a late dinner, I'm going home late tonight and I'm going to eat a late dinner and I'm going to lay down to go to sleep, my esophagus will be flat. If my esophagus is flat while my stomach is full, it's a prescription for acid reflux. Tobacco use increases reflux symptoms. Wearing tight-fitting clothing with a belt that's tight after a meal prevents that stomach from being able to expand into space to accommodate food. Now, working our way down to other medical management options, we can talk about acid suppressants and antacids. So H2 receptor blockers are forms of acid suppressant therapy, such as Pepcid, that are mild to moderate acid suppressants. And for many people with mild to moderate reflux symptoms, this class of medication alone is sufficient to keep symptoms at bay. Moving our way up, there are proton pump inhibitors. Proton pump inhibitors are a class that permanently block a specific channel in the stomach that secretes acid into the passageway of the stomach, and they're our most effective medication for suppressing acid effectively. Finally, for patients that have a very sensitive esophagus and a hypersensitive esophagus, we can use neuromodulatory agents to change the neural pathways that send pain signals from the esophagus to the brain. So a lot of what we do on a day-to-day basis is counsel our patients on the risks and benefits of proton pump inhibitors, or PPIs. And the data, even the sketchiest data in our literature that comes out immediately hits the front page of a newspaper. So the New York Times had an article that put the fear of death in patients when it said heartburn drugs may increase risk of early death. The paper was terrible and limited by confounding. Nexium and proton pump inhibitors all the possible side effects. So this is really the crux of where we are today, is counseling patients on what do we know, what don't we know about this class of medications. So when we weigh these pros and cons, proton pump inhibitors, again, omeprazole, pantoprazole, lansoprazole, or brand names Prilosec, Nexium, Dexilant, Protonix, these are our most effective class of medications to block the production and secretion of acid into the stomach. The pros, they really help heal esophageal injury and gastric injury that can occur from acid. So acid is designed to break down chemical bonds. And although the GI tract has a protective layer that helps prevent injury, that can get denuded and broken down, leading to an ulcer. Once you have an ulcer or an erosion, which is sort of a pre-ulcer, symptoms escalate. Heartburn symptoms will rise if there's injury to the esophagus, and PPIs help heal that up. Additionally, for the subgroup of patients that have Barrett's esophagus, which is a change of the lining in the esophagus in a patchy distribution that can be considered precancerous, PPIs have been shown to reduce the risk of simple Barrett's esophagus to very advanced Barrett's or cancer. Additionally, I'll say that PPIs do work well in many patients to control symptoms of GERD. Now, when you weigh these pros and cons, you've got to know that there are several safety concerns that have been associated with long-term PPI use. So PPIs will change the pH of the stomach and other areas of the GI tract. So this has been shown to have a slight risk of certain GI infections to occur at a higher rate than people not on PPIs. This is a statistically significant risk, although the overall risk remains extremely low. There's a risk of the drug as it passes through the GI tract, inducing a microscopic colon inflammation, which is self-limited and essentially will stop if the drug is withdrawn. Many of our patients have concerns about osteopenia, which is pre-osteoporosis, osteoporosis being decreased bone density. And what we do know is that PPIs will decrease the absorption potentially of certain minerals and vitamins. So calcium absorption may be affected. Calcium carbonate is a form of calcium that needs a slightly acidic environment to have the calcium be able to be absorbed. This can be, ironically, this can be overcome with a slightly acidic meal. I'll also add that there are many forms of calcium supplements that are absolutely not affected by PPIs, specifically calcium citrate, which is an over-the-counter form of a calcium supplement that has no issue regardless of the pH or lack thereof in your stomach. Other types of absorptive issues that have been raised, some patients may have a little bit of a decrease in the amount of B12 or magnesium absorption. And again, these can easily be overcome with the use of a multivitamin as well. There's a risk raised of acute allergic reactions. There's something called acute interstitial nephritis, which is an allergic reaction that can occur in the early phase of using these medicines. It's not something you see months out, it's early on. And again, all medications can have the risk of an allergy. Now, I want to stress there's really poor data on most of the side effects, and a lot of that has to do with what we call confounding. When you put two groups to study, they may not be the same medically. So there was data regarding chronic kidney disease, dementia, pneumonia, cardiac disease, and the study designs were all very poor, and I don't trust them whatsoever. So for example, there's a study on cardiac disease, and essentially what it found was patients that were on PPIs have a higher rate of cardiac issue, like a heart attack. But actually, when you look at the data, the study groups were not the same. People go to their primary care doctor, say, I'm having chest discomfort. The primary doctor thinks maybe it could be maybe it could be acid reflux. They're on a PPI, and then they have a heart attack or something of that nature, but it has nothing to do with the medicine. It's just that now there's an association. So association and causality are not the same. This is essentially the crux of where we are with pros and cons of the medication class. Now, I want to steer us to a different topic, which is managing the complications of acid reflux. So one of the major complications that we see in patients with acid reflux can be Barrett's esophagus. And most patients with reflux do not develop this, but about 2 to 3% of patients, even per year, may have Barrett's esophagus develop in the setting of chronic ongoing acid reflux. Chronic reflux is a risk factor for the development of this change, and this is considered a precancerous change in the lining. In this picture on the right, you're looking downstream in the tunnel of the esophagus, and this tissue in the darker pink is actually what's called Barrett's esophageal epithelium. This is the Barrett's, all of this deeper pink tissue. The lighter color here, this color here is the normal esophagus, where this color here is the Barrett's type tissue. We're establishing a Barrett's registry to track patients at Newton-Wellesley Hospital with this condition so that we can continue to follow them over time and be sure that we're surveying them appropriately. Now, we also have the ability to do advanced eradication techniques of Barrett's esophagus to eliminate it from the wall of the esophagus. And one of our tools is called radiofrequency ablation. This picture here, what you'll see is the Barrett's tissue over here, the normal esophageal tissue over here, and this black line, this is an endoscope with a paddle put through it that we can touch onto the Barrett's type tissue and ablate it with radiofrequency waves, which eliminates the Barrett's off of the wall of the esophagus. Additionally, we can do what's called endoscopic mucosal resection. So endoscopic, meaning it's using a scope. Mucosa is the lining of the esophagus, and resection is just taking away that lining. In this picture, what you're seeing is in blue is a lifting agent that we can put under the esophagus by injecting it under the lining of the esophagus. If I see a focal area that looks worrisome for advanced changes in the Barrett's segment, I can do this and then snip it off with a snare or other tools to eradicate the area of concern. I am going to turn this right back to my colleague, Dr. Paranjape, for ongoing talk about the surgical management for acid reflux.
Thank you, Dr. Levitsky. That was fantastic. I'm sure everyone not only enjoyed, but they probably have a lot of questions for Dr. Levitsky. We're going to take them later, but I'm going to switch to gears and talk about what is the role of surgery, when do we do surgery, what kind of surgery, and what are some of the benefits, and what can we do with surgical treatment. So thank you, Dr. Levitsky. Again, I'm going to share my screen. So bear with me for a second here. apologize for the little back and forth here. So anti-reflux surgery, the goals are very clear. I'm going to go into some of the anatomy lessons here, and some of you will enjoy. Some of you will say, oh, I don't want to see the anatomy, but there's no gross pictures here. It's pretty basic stuff. But I think you need to understand, when we talk about surgery, we need to understand the basic anatomy. And so essentially what surgery does or wants to do is reestablish the relationship between the different anti-reflux components, which includes our diaphragm, which is our breathing muscle. We're going to see more pictures in the next slide. But diaphragm is our breathing muscle, as we can see here. This is a little cartoon. The lower esophageal sphincter, as well as the two crura, and the pharyngoesophageal ligament, which is this little ligament that connects with the esophagus and the rest of the diaphragmatic structures. It also, at the same time, has to allow normal swallowing, belching, or vomiting when we are sick. And so it's a fine balance between making that that opening nice and narrow, at the same time allowing us to do all these normal physiological functions of swallowing and burping and vomiting. And so if you look at, again, some of the anatomy here, this is the diaphragm, which is our breathing muscle. So every time we take nice deep breath, this is the muscle that goes up and down. And this muscle divides our entire torso into two different cavities: the chest cavity that's above, and then the abdominal cavity that's below the diaphragm. So every time we breathe, this is the muscle that goes up and down. This muscle is basically traversed by the esophagus, as you can see here, and that leads to the junction of the esophagus and the stomach that's below the diaphragm. And this junction, as you can see here, and this is the endoscopic view that Dr. Levitsky or I, when we do endoscopies, that's when we see. Many of you who are listening today have had endoscopies and have seen these pictures. But this picture should be the normal picture, where, as you can see, it's nice and narrow, where the esophagus meets the stomach. And this is how it should look normally. However, in certain conditions, this is not so. For example, if this sphincter is not the way it's supposed to be, or it's wide open, or in certain conditions, like we're going to see in the next slide, a condition called hiatal hernia, where there is an actual defect in the diaphragm, this opening is this big. And so let's look at those slides. So if you see here, this middle picture represents the hiatal hernia picture. Many of my patients, when I try to, talk to them about hiatal hernia, they don't even know what hiatal hernia means. They know that what a hiatal hernia, that they have hiatal hernia, but they don't know this picture. And that's why, we, Dr. Levitsky, myself, we have this whiteboard in our room, and we'd like to draw pictures so that we can show this sort of basic anatomy to our patients, so that they understand what mechanical problems they actually have. And so one of the mechanical problem is this: when, as you can see, there's a defect in the diaphragm, and part of the stomach has escaped up into the chest. And as you can see, part of the stomach here is above, part of the stomach is below. So this is causing almost like an hourglass type of appearance here. And this is a pure mechanical problem. This can lead to certain symptoms, and that is a mechanical problem where we encounter severe reflux. Another mechanical problem is seen in picture number 1, when there is no significant hiatal hernia. However, this lower sphincter that Dr. Levitsky was mentioning, This sphincter is wide open. In other words, not the narrow picture that we saw in the earlier slide, but it's wide open. It allows reflux all the way up into your throat and sometimes into your lung. The third picture is sort of the extreme picture where the defect in the diaphragm is so big that almost the entire stomach, as we have seen in this picture, has gone up through that hole and is upside down in the chest. And these kind of large hiatal hernias, we also sometimes call them paraesophageal. It's a technical term for those hernias. These big hernias can actually press on other things. So they cause different mechanical symptoms. They can cause pressure on the lungs. They can cause pressure on the heart. Because they're upside down, they cause different kind of symptoms. And this type of hernias are at a risk of what we call strangulation, or they can rotate. And just like any other hernia, it can be present as a real emergency where it rotates within the hernia and causes strangulation of the hernia. So how do we really treat these mechanical problems? Like we all know in our day-to-day lives, when there are mechanical problems, there are mechanical solutions, and we have a number of them which are excellent. So talking about the first mechanical solution, we can offer surgery with no incisions. How's that even possible? Surgery without incisions. But that has been actually mastered now over more than a decade. And one of the common options is called the TIF procedure. Some of you have already heard about this, or some of you have seen our videos on our website. So if you go to Newton-Wellesley Heartburn Center website, there is a nice video of this. One of them, we are going to actually see it in our next slide here. But essentially what happens is this little device can reconstruct our junction of the esophagus and the stomach as shown here. And it creates a sort of a 270-degree new valve at the esophagus and stomach junction. So if you look at this, this is a little video, and that will essentially show you how this is done. So this video, as you can see here, the scope is being passed into the mouth all the way into the esophagus. And now the scope is looking backwards like a candy cane. And so we are now looking backwards to look at this G junction where a flap of the junction of the esophagus and stomach has been pulled into this device. And then we fire H-shaped fasteners directly here into this. And now it creates a nice, beautiful 270-degree valve with multiple fasteners. This is the end product. This is how it looks. And this creates a beautiful sort of a valve that creates a long-term sort of a new valve that's works against the reflux mechanism. We happen to have the highest experience in Massachusetts for TIF surgery. It is one of the most patient-friendly procedures with minimal discomfort because patients, feel like they just had an endoscopy. There are no incisions, so there are no complications related to the incisions, such as incisional hernia, infections, things like that. It's a very quick return to work. And about 80% of the patients have long-term cure or freedom from all the symptoms from the disease, and also they're off of their PPIs 8 out of 10 number of times. There are other options such as robotic surgery or laparoscopic surgery. So a little bit going back to the basics again. The picture here, which you see here, is a picture of a large hole. As you can see, this is the diaphragm right here. This is the liver here that we have pulled up. And so we're going under the liver, and this whole big, huge defect is the hiatal hernia, where, as you can see, most of the stomach has sort of gone into the chest. These big defects have to be repaired by being in the abdomen, but you have to be outside the stomach. So here you cannot do it through your endoscope method or the TIF method. You have to be inside the abdomen to close this defect. And this is done by tiny, tiny incisions like shown here in the first picture. And what we do essentially is we go in and go all the way through this into your chest, the patient's chest, and completely dissect this sac, hernia sac, into the chest, and sort of reduce the hernia and all its contents, the stomach, back into the abdomen where it belongs. This little picture shows you how that defect is repaired. So this big hole is basically will look like this, because now all the muscles are brought together. And then we do what's called a fundoplication, which is a new valve that's created by using a part of the stomach. So if you see in this cartoon, this part over here of the stomach is taken, it's rotated behind the esophagus and to this side, and then tied in the front. It's almost like taking the stomach, going around the neck, and tying a beautiful bow tie in front of the esophagus. And so this creates a new valve, which again works against the reflux mechanism and gives a long-term protection for any kind of reflux. The robotic and laparoscopic surgery, again, also causes minimal discomfort. Even though these are tiny incisions, they're so small, most of them you can't even see them. The laparoscopic anti-reflux surgery is actually the gold standard of any anti-reflux surgery in the world. The average length of stay at our facility is only 1 day, sometimes even quicker in some patients. They can go home in the same day. This is extremely effective. Many decades of data have shown that over 85% have long-term freedom from symptoms and PPIs. That means, over long-term in high volume centers, which includes ours, patients are, their quality of life improves significantly, and they're off of PPIs for the most part. This little diagram here, as you can see, shows more than 5-year data of how their quality of life scores improve. So the higher the score, basically the worse their quality of life is. And so over 5 years, the maximum score can be 75, but as you can see, over 5 years, it does slightly go up, but not much, but it's significantly better than where they started. And so this is a very long-lasting sort of repair. To summarize, based on what Dr. Levitsky said and in this lecture, Newton-Wellesley Heartburn Reflux Program brings your multiple specialists from all different specialties together. There is a growing surgical anti-reflux cure for chronic heartburn. You don't have to necessarily suffer every day from these chronic symptoms and be stuck to only limited choices. We were one of the first ones in Massachusetts to start incisionless anti-reflux surgery program. Like Dr. Levitsky mentioned, we have an upcoming registry that's coming up for Barrett's. Currently, such registry does not exist in most of the hospitals. This will give us access to sort of having constant reminders to our patients regarding their screening programs and how we should be aware that we don't want these Barrett's to turn into cancer. And so there will be experts available to you to either offer some of the treatments that Dr. Levitsky mentioned, or even surgery. There's enough data now to show that anti-reflux surgery in Barrett's patients can actually not only stop their progression to cancer, but can, in some cases, reverse the disease into normal looking lining of their esophagus and stomach. We all have actually started this year a unique conference or course, which is called MINT, which is a minimally invasive and novel therapeutics course. This is an educational program that has been started with Harvard Medical School, and we've had our first international conference earlier in September this year, which was extremely well attended by thousands of registries. And this is going to be a recurring theme every year for all the learners in the medical field that can give state-of-the-art updates on the field of reflux. And then we also have outreach programs such as this for education of our common communities that we serve. And we have a very nice website, as you can see here, Newton-Wellesley's website /Heartburn, so nwh.org/Heartburn, where you can get even more detailed information of all these things. There is a beautiful number to remember. It's 964 GERD, easy to remember. And so you can call this number anytime, and one of us can get back to you about your questions. And lastly, to summarize, essentially a true relief from heartburn is not in one pill. Unfortunately, as we know, treatment of reflux has become a reflex, in the sense that a lot of our patients take this over-the-counter medications without really going down to the root cause of why they're having a heartburn. What can they do about it? What's a comprehensive approach to their particular problem, which could be any one of the spectrum that Dr. Levitsky and I described, and then ultimately coming up with really tailor-made solutions that can help a particular patient. And so this team approach has been sort of the new way of how a care is delivered. And we are extremely proud that we have such a wonderful team here at Newton-Wellesley, and we are at your service. We're happy to help. I would like to conclude this sort of educational presentation with this slide, and both me and Dr. Levitsky will be happy to take some questions. I think Lauren also has some comments and some ending remarks. So thank you very much.
Great. Thank you so much, both of you. I'm always fascinated because I learn so much when, when I'm moderating these programs, but and this is definitely, I learned a great deal right now. So we do have some great questions that have come in. So I would love to provide those to you, and then I'll let you both decide who's going to answer, if not both. So the first question is, does eating a Mediterranean diet help reduce the effects of reflux?
I will let Dr. Levitsky answer that.
So, what I'll tell you is that different people have different food triggers, and it's not really a one size fit all. I think a Mediterranean diet in general for overall health is a winner. Not taking reflux, but aside for a minute and looking at the global perspective as what you can do for cardiovascular health, this is a winning diet. There are parts of a Mediterranean diet that can be highly acidic, and maybe you feel symptoms from acidic foods that may worsen reflux symptoms. I'd say that, the common offenders: chocolate, alcohol, peppermint, caffeine, citrus, tomatoes, tomato sauce, highly fatty foods, eating large quantities of food at one time are some of the heavy hitters for food choices that cause reflux.
Thank you. This question is about PPIs. So aren't PPIs not recommended for those with osteoporosis?
Yeah, this is a very delicate, tricky question. And so let's look at what we know. So insoluble calcium, meaning calcium carbonate, requires an acidic environment to be optimally absorbed. So as a result, if you take a drug that reduces the stomach's acid secretion, and that would include PPIs, and to a much lesser extent, H2 receptor blockers like Pepsid, as a result, you may reduce calcium absorption. Calcium absorption decreases with aging, and a further reduction in calcium absorption with the addition of these drugs potentially could have an impact on skeletal health, particularly in older individuals. The more important clinical question is, what is the data about PPIs and how they affect fracture risk? We've actually done what's called a meta-analysis, where we pool all the data that we have that tried to answer this question. And the pooled data showed a very modest but significantly increased risk of patients that have been on PPIs with risks of fracture. Now, what we also know is that this type of calcium, i.e. insoluble calcium, calcium carbonate, is only one form of calcium that we can ingest in our day-to-day lives. The PPI risk can be overcome by ingesting a slightly acidic meal to make calcium carbonate more available. Alternatively, you can use a calcium supplement like calcium citrate, which does not require acid whatsoever for absorption, to augment calcium intake. 1,000 to 1,200 milligrams of calcium with vitamin D can be easily obtained with calcium citrate use. So that is a long way of saying, I don't say there's a slam dunk that you can't use PPIs if you have osteoporosis, provided you take those precautions and likely take a calcium citrate supplement.
Great. No, thank you for that answer. That was fantastic. It was a worthwhile long answer. So thank you. And I'm just going to have an additional PPI question that also was followed by that. I have been taking a PPI for 20 years. The 30 milligram dose works completely. Should I try to wean off it every so often to try to take less, or possibly stop needing it?
So I know I'm a surgeon, but I'm going to take that question, and I'll have Dr. Levitsky add in. So one of the, PPIs in general, as Dr. Levitsky mentioned, they're very safe medications. And this is a surgeon telling you this, right? So it's good. The good thing about PPIs is that it takes the symptoms away. The bad thing about PPIs is that it takes the symptoms away. And what that means is that even though you're taking this PPIs and it works fantastically, when you say that, you're saying that your symptoms are under control. But what the take-home message of today is that you still, when you're taking PPIs, you still need surveillance. You still need, certain checks. And that means that you may have to see Dr. Levitsky or me or someone, like endoscopist, to make sure that you don't have those underlying things such as Barrett's going into early cancer and so on and so forth. And so you're right. You can almost wean them off and see how it goes. However, again, the take-home message is that make sure that you're being there is a surveillance going on endoscopically, because it's not like you're going to have new symptoms if you develop Barrett's. You have the same symptoms. It's just that you don't know it because you're taking PPIs.
Okay, great. Thank you. So I think this is one for you, Dr. Parancipé. What makes one a candidate for TIF versus laparoscopy?
Great question. And so like I tried to show you the anatomy, one of the essential part of the TIF, or the incisionless option, is that you have to have a hiatal hernia that's extremely small, that technically less than 2 centimeters, or no hiatal hernia, but a faulty valve. What that means is the valve is not working. And so me or Dr. Levitsky or we together can go in and basically repair your valve from inside the mouth. When there is a bigger hiatal hernia, the problem is in the diaphragm, as you saw, that there is a hole in the diaphragm, and that has to be repaired. And to repair that, you have to be outside your stomach, but inside your abdomen to fix that. And that will be done either laparoscopically or robotically. I hope that answers it.
Thank you. And this question is, what do you think about LPR, silent reflux? Any differences in approach?
Dr.
I'll
Levitsky
tackle that one.
Loves this, yes.
Yeah, well, I will tell you that we see lots of patients with complaints in their neck day to day. And the neck is a tricky area because it's the meeting of all the minds. It's the meeting of ear, nose, and throat doctors that deal with postnasal drip. It's the meeting of the pulmonologists who have patients with cough, and it's where the esophagus begins, which is my neck of the woods. So one thing about LPR is we need to make sure we know what we're dealing with. And the tool that I showed you, which is a catheter that goes into the nostril and down the esophagus and is able to monitor for acid reflux, not only at the tip of the catheter, but how high does reflux go, is a very helpful tool to look at LPR. If someone has a cough, and that is what is being called laryngopharyngeal reflux, well, when the cough occurs, we can use that tool to look what happened in the 5 to 10 minutes before the cough started. Was there an acid reflux event to the neck? Yes or no, right? So the other way that our evaluation for considering LPR is a little different. We may try to treat for postnasal drip for a while. We may pull in our pulmonary colleagues to see, is there a reactive airway, as well as treat you for acid reflux. So there's a meeting of the minds there.
Okay, great. Do any of these surgeries apply to Barrett's?
So yes, there are different treatments of Barrett's depending on what type of Barrett's you have. And so if you have the advanced Barrett's, we have, Dr. Levitsky showed you beautiful pictures where endoluminally, that means through the endoscope, we can eradicate the Barrett's, right? And that's one procedure. However, if you are young and you have decades of life in front of you, then you don't want to be in that area where you want to 10 years down the road you have Barrett's, and same thing again. You want to control the cause, which is, let's say, a hiatal hernia that caused the whole reflux to begin with. Then you can also follow up with that and have the hiatal hernia fixed. So then down the road, you won't have all that insult from all the acid coming back into your esophagus and causing Barrett's again. So yes, in fact, Barrett's is a very strong indication to actually do something about it, because again, we don't want the disease to progress from normal to Barrett's to then potential early cancer and then to cancer. So when there is the Barrett's, again, there are, not to scare you, but Barrett's has different types. There is what we call non-dysplastic Barrett's, which for the most part, we monitor it and make sure it doesn't progress. But if you are already into the advanced Barrett's phases, then we very rapidly will advocate aggressive treatments, which are extremely, extremely effective.
Great. And this is a little bit of the same topic and very specific to someone's situation at home. I have a son who has profound intellectual disabilities. He has been diagnosed with Barrett's. Would the treatment you describe be possible for him? He is not verbal. I don't know if you can comment on that.
Dr. Levitsky. Yeah.
Sure, I'm happy to tackle this one. Thank you. So first of all, as Dr. Paranjape mentioned, Barrett's is a spectrum. And I will give you reassurance that the vast majority of patients with Barrett's don't have advanced precancerous changes. And for those patients, we generally survey Barrett's with endoscopies to get samples microscopically to look for any signs under a microscope of more advanced changes than we see visually, as well as recommend chronic proton pump inhibitor therapy. There has been data that suggests a lower risk of progression to esophageal cancer or advanced precancer with medications. So your son should certainly have a gastroenterologist involved to periodically look with endoscopy at that area and sample this. If there's no advanced precancerous changes, that could be as infrequently as 1 out of every 3 to 5 years, depending on what he has.
Great, thank you. This question is, I have a small hiatal hernia, but ongoing abdominal bloating, gas, and am currently on FODMAP diet almost exclusively. Does your collaboration go into the intestinal area as well?
So, one of the benefits of this, of our entire team approach, is that we have expert gastroenterologists, we have the dedicated dietitians in our team. And so one of the good part of this program is, as you can tell, not every patient that comes to us are going to only have reflux. They will have other things. They will have celiac, they will have, some inflammatory bowel disease or some other intestinal issues as well. And so since we have a team approach, the benefit is that we're able to tackle this from all different sides. And so that is, I think, to me, is one of the key benefits of a team approach to care. And I think that's where this team approach will be beneficial to you.
Excellent, thank you. I very much agree with that in the program that you've built at Newton-Wellesley. This question is, how difficult is it to make a definitive diagnosis for hypersensitivity?
Well, so this comes back to those tools that we have, the pH tests that I described. So if a patient has one of those types of tests and is having many, many symptoms over the course of either a 24 or 72-hour study, and there's no acid reflux or minimal acid reflux, that would be potentially suggestive. Failure to respond to acid reflux treatments and lots of symptoms may also suggest that it may not be truly reflux induced. And so there's not a specific test that proves visceral hypersensitivity or esophageal hypersensitivity, as much as the clinical outcome with therapies for that diagnosis and a failure of other diagnoses to come through on our diagnostic testing.
Excellent, thank you. So this was a follow-up to a previous question that we answered, that you answered a little bit ago. After years of PPI and diet changes, will the, and I'm sure I'm going to say this wrong, sphincter ever heal and close in a normal way? Oh, I've learned something this evening. So would it ever heal and close in a normal way?
So again, it depends on, where we are and where we started. Typically, if there is a mechanical problem, or let's say in this case, sphincter, that means the valve is sort of abnormally functioning, either by itself or because there is a small or large hiatal hernia. Typically, that will not go back to, the anatomy is not going to go back to normal anatomy. It is the symptoms that your diet and lifestyle, weight reduction, all those things will add to, decreased symptoms because you're having decreased reflux. And so it will go back to, the initial evaluation, how things are, how advanced or if there are any complications related to your valve not functioning, and then sort of monitoring that and where we are down the road. And then we can offer either mechanical solutions or continuing lifestyle modifications and or adding more medicines as required, and or a combination of all this. And so I wish there was a blanket answer to your question, but basically this is the basis of that, that it will not go back to normal anatomy. However, there are modifications from all different sides, more mechanical, medicine, and lifestyle that can control this and give you a good quality of life.
I will add that the reality of the GI tract is it's more like the Mass Pike and not a little one-way side street. So things are designed to go in both directions, right? So I understand that you're very concerned about the anatomy here. We don't, the lower esophageal sphincter, even in normal people, will have things regurgitate. And so if you're really concerned, we'd be happy to look into the sphincter and make sure it looks okay.
Excellent. And our questions are slowing down a little bit, but I purposely have left these last few to ask you before if you had any concluding remarks, and then I have a few things to say as well. But people are definitely wondering if the physicians in your group are taking new patients, how to get referred. Do they go to their PCP, or how can they get into your service? So that's a great sign with all the information that you've provided. So if you could share that with everyone, that would be great.
Thank you. I'm going to share my slide again so that everybody can have that number. So the good news is that there is just one number to call. There's a coordinated care. And so, this one number will get you to one of our coordinators, typically Anna, who will get you all your information. You don't need a PCP referral. There are some insurances that will need, and in that case, Anna will let you know, but typically you don't have to do that. She will typically take care of that. And like we've been saying again and again, that even though Dr. Lovitsky, let's say, sees you first, or I see you first, we have the team approach. And so you have the access to all of us through just one number at one site. And we all are taking new patients. And so even though you will see initially maybe one member of the team for your initial evaluation, and it could be also one of our fantastic physician assistant, who's Alex, and you might see her first. It doesn't matter. We all sort of work on a common clinical pathway. And so we all talk to each other. We discuss some of the cases together. Every now and then we have a conference where we actually present and discuss some of these cases where all of us sort of put our minds together. And so we do this multidisciplinary approach for you. And so you have the access to all of that. So this is the number to call. You're happy to tell Anna that you want a specific physician versus, like I said, you can just see anybody that's available at your convenience. You still have access to all of us.
And we have a dietitian ready to see you at the time of your appointment with either Dr. Pranjape, myself, or the other members of our team.
And that's a very specific, that's a very good point, because just to let you know, most of the centers in the country don't have a dedicated dietitian in the program. And part of that is unfortunately due to the fact that insurance does not cover a dietitian's visit in these kind of programs. We have actually made it very simple for you. There is no charge for our patients when they see the dietitians, number one. Number two, the dietitian is available innumerable amount of times. So if you want to see the dietitian more frequent, it's available it's part of our program. And so That is a great point, Dr. Levitsky, and that is one of the highlights of our program, that just with the dietary modifications, our patients, together have already lost thousands of pounds, if that's even conceivable, and just by modifying their diet and their lifestyle, and that has led to remarkable improvements in their symptoms just by doing lifestyle modifications.
It's amazing, and I'm sure that the fact that they do have the ability to go any number of times is significant for your patient population. That's a phenomenal piece of your service. That's great. And I do have to just highlight the comment that came in that you have made this very easy to understand in presentation form. So kudos to both of you for doing that. Is there any other thoughts that you have that you want to share with everyone before we kind of conclude things?
No, I think it's been a pleasure. I think, this is a very common condition, and yet we don't have a sort of a comprehensive approach to this common condition. And we're extremely proud and happy to present this team approach to all of you. And we all are always available. Let us know how we can help you. And again, thank you, Lauren, and everybody else to give us this opportunity today.
And I'll add one last thing. In the era of a pandemic, we've opened this up to patients both virtually as well as in person. So we can see you in either context. That's
great to know. That's an important feature to have at this point in time. So that's excellent. And I know you're busy with both ends. So that's great. And I did want to tell people that we are going to be, as we do with every webinar that we do, we will be sharing resources as well as the recording of today's session so that you have this and can go back to it. And that will be sent to everyone who registered for the program. And again, between the two-part series, we've had great attendance at each of them. So a great topic that we will probably repeat at a future point in time. And then just as a reminder, the Newton-Wellesley's community program, we have continuous topics that get covered. And so we do encourage you to visit our website at www.nwh.org. We update that frequently, and it does change through kind of each seasonal iteration that we have for programming. So please look through that and spread the word to your family and friends. And I really want to thank everyone for joining us this evening, for Dr. Paransape and Dr. Levitsky for this fantastic talk on a topic on an important subject. And I hope everyone has a wonderful Thanksgiving as you move forward in the week. Thank you.
Thank you again.
Have a great night.